Okay, so the next thing I'm going to talk about is kind of subjective, like the subjective portion of your note, and kind of like workflow morning stuff. So I'm just going to show you how I write my notes. Right now I have a caseload of 4 patients, but I think this could be adapted fairly well. So I just take a flat sheet of paper in the morning, and obviously you're going to have like your sign out sheet, and I think that's great because there's a lot of stuff you don't want to write down. Like I don't want to write down the meds every morning. This sheet is really for like my plan, my quotes, and like the specific variables that I need to be kind of keeping an eye on for each patient. So when I come in the morning, I'll write my patient's name up in the top of each of these little squares, like each of these little quadrants. Name, age, and I'll write the type of hold they have. So like here in California, you can have like 5150 or 5250, or something more lengthy, and then I'll write down why. Is it because they're DTO, aka danger to others, DTS, danger to self, or GD, gravely disabled? And then the last thing I'll always write down is when that hold will be kind of resolving. And so that's kind of like the very top of each little quadrant. And then underneath their name, I'll put their day's vitals, and I'll keep a highlighter in my pocket. And so if any of those vitals are abnormal, I'll just highlight it so that I remember to follow up on that during my conversation with the patient, and also to discuss it during rounds and maybe get a follow-up set of vitals. The next thing I write, so here's what it looks like so far. So I have name, age, hold status, expiration date, and then I have my vitals right here. And then right next to that, I'll put sleep, meal intake, bowel movement, ADLs, group, if you have like group or something that like a patient's attending, and medications, and I'll do 1 line for scheduled meds and 1 line for PRNs. Like this. So sleep, meal intake, bowel movement, ADLs, group, and then meds, and I'll have scheduled and PRNs. And I won't even label these anymore because this is how I do it every single time, but if you want to start with labeling it, you can. And I'll just kind of put in there, so the number of hours of sleep that they got, and I'll get that from, the chart or nursing, meal intake, and hopefully that's recorded, but you can also ask the patient about it. Bowel movement is really helpful to keep track of, just because there's so many medications that your patients might be taking that contribute to constipation. And then ADLs is there documentation that they're showering, that they're brushing their teeth? Are they performing this independently? Are they performing it with prompting or without? I'll put all of that information there. And then groups, I don't know, it can be helpful as a patient's approaching discharge to document like, oh, they're starting to attend way more groups. Like this is a sign that they're prepared to go back and enter the real world, or to enter back into a lower level of care. And then finally, medications. So scheduled meds. Again, no cheeking. Are they taking it with prompting, or do they do it kind of independently? And then any PRNs that they used. And I'll write down the name of the PRN, the milligram amount, the route, and then like the hour, the time that they took it. And then the other thing I put in here is interval events. And so this is where I spend the morning reading all of the nursing reports from the night before, any notes from group, any notes from the social worker, just anything at all. If I see something that I think will be kind of a useful nugget to document, either to show how we're working towards refining our differential diagnosis based off of maybe a behavior they displayed, or if they displayed some sort of like agitated behavior that could help you in your assessment justify why they need this higher level of care, that's all going to be written down here. And I try to make sure whatever information I'm documenting in this little subsection, I also mention where it came from. So did this come from the social worker? Did this come? Because you're going to use that when you write your note at the end of the day. And then my next thing I go do is I just leave like the middle section in here as my like quote section. So when I go talk to the patient, I'll highlight anything up here that's kind of outside of like the normal ranges. Did they sleep very little? Did they eat very little? Did they have like this one event that happened overnight? I'll highlight it. And then when I go talk to them, I do the mental status questions that I already reviewed, but just to quickly go through them. How are you feeling? Any thoughts of hurting yourself or others? How would you feel if you woke up dead? What are the voices like that you experience? Tell me more about the hallucinations that you experience. Do you know where you are? Do you know what today's date is? Memory and concentration questions. Cover all of that, and then also cover any of the things that are highlighted from in here, and that way I don't forget. Because sometimes your conversations can kind of derail really quickly. And then the bottom section right here is where I write my plan, and for that, I'll organize it by, like any medication changes for their psych meds, any like medicine type problems that they're experiencing. So like if they took a PRN for headache, I might put that in there. If they had a complaint of any physical symptoms, I'll put that here, what I'm doing for it. And then I'll also put in my plan section, like, what are my discharge plans? Like, have I discussed this with the patient? What does the patient think their discharge plans are? And that way, in this little area, I've kind of covered everything I need to know offhand about my patient, outside of what's included in that, like the morning report sheet that you print out every morning. And I'll just do that for every single patient. I'll fill out like kind of this top third, and then I'll go talk to them, and I'll get any good quotes. And then by the time I've done that, I can kind of fill in this area very functionally in preparation for rounding with my attending. So kind of this is still supposed to be a subjective. So in terms of the subjective, what you're documenting is the conversation you've had with your patient, and ideally you're using as much of their own words as possible. And there's certainly an art to this. You want to be efficient, I think, is the big thing that has been kind of highlighted to me, is instead of writing, when the patient was asked about their lack of bowel movements, they said da 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 da, and you just want to be, maybe you make that cleaner and shorter and say just like direct quote from the patient regarding bowel movements, or however you can make that like short and snippy. You also want to, a lot of information does get covered in the mental status exam, which is going to be documented in the objective portion of your note. And so rather than just repeating like patient denied SI and HI, which will be in your mental status exam, this is the area where you can add nuance about how the patient did this. This is the area where you're going to basically justify some of the notes you put into your mental status exam. So try to create detail there while also being efficient. I know, super helpful, Christy. And then the last things you want to do, so the way you can kind of organize it in your mind while you're writing it is symptoms. So if you have a patient who's depressed, what did you cover in terms of the symptomology from Psychiatry Caps in your discussion? If you have a patient who is manic, what from your like discussion of like dig fast criteria did you talk about? If you have a psychotic patient, what features of their psychosis did you discuss? Give us the nuance of the voices in their head, etc. So symptoms, first S. Second is side effects. So are they experiencing any side effects from the drugs that you've given them? Any EPS side effects? Do they deny those side effects? Great, document it there. And this is also a good place to kind of train yourself to maybe in the morning look at the medications that they're taking and just like quickly run up to date and check what side effects are most common with that. Is it orthostatic hypertension or hypotension or something like that? The next thing you want to do, so we've got 2 S's, symptoms, side effects, safety. And this is again where I would say add the nuance to justify why you do or do not believe there denies SI or HI. And then the last thing I put in is medical things. So did this patient complain of a sore knee? Okay, what did you educate the patient about? What did you offer to the patient in terms of a physical exam? So whatever the medical problem is that like they've been complaining about, because a lot of these patients are super somatic and you want to treat them well and then create that therapeutic alliance. So what is it? How serious is it based off of like their description? And what did you do to help them? How did you educate them, etc., etc.? So that is your subjective in a little nutshell. And this is how I organize my notes in the morning. I think it's pretty efficient. And then sometimes if I know I'm going to present on a patient, I'll quickly write like my mental status exam, like over here. But I find if you just kind of do things in the same order every day, you don't even have to like pre-write your mental status exam because you've been asking the questions to get you through that really efficiently. I think that's it. I'll do a video about assessment at some point, and kind of what I've learned so far about how to write a functional assessment. I think that's really where the art of psychiatry comes in. And I don't pretend to really be good at that part yet, but I think it comes in baby steps, and I'm happy to tell you what I've figured out so far. And then I'll do a video as well about just like the process of my sub-I, and maybe I'll update that as I do kind of another sub-I this year. But thanks for hanging out, and I'll see you later.